Miami Beach. This is Dr. John Bennett broadcasting for Neurosurgical TV. Miami Beach really looks like this. We're honored to have the presence of Dr. Ibrahim Sabeya, a neurosurgeon educator from Jordan, who's been doing these lectures for a long time. And let me introduce Verdab to introduce him. Hey, Verdab.
Hello, Dr. John. How are you?
Very good. Could you just introduce yourself, what you do, where you're at, and stuff?
Yeah, I'm Radab Al-Khataiba, an officially certified neurosurgeon since last year by the Jordan Medical Council, and also a Jordanian fellow in the European Board Examination in neurosurgery. I've been training the residency here in Jordan, and I've been traveling all Europe and have a 6 month experience in my clinic. So today we are honored again, as every week, with Dr. Sabeh. Professor Sabeh is one of the well-known neurosurgeons in Jordan and the Middle East for his diverse contributions to neurosurgery and neurosurgical management in the Middle East. He has been the second vice president for WFNS, and he has a lot of other contributions in the neurosurgery knowledge. Dr. Sabeh, we're honored to have your presentation and the short experience again today. So would you please start your presentation?
Thank you, Rada, for this introduction. We'll start immediately. Okay, so good morning, good afternoon, good evening, wherever you are. My name is Ibrahim Sabeya from Jordan, and I chose today to speak about something special, that is intracranial bleed and how we behave about it. I'm transmitting from Amman, from the Farah Medical Campus. This is a true picture. This is a true picture of the stars at night. If you visit Wadi Rum and Petra, this is what you see. You'll never ever see something like this in any place on earth. Beautiful, bright, lovely stars that you can see in Wadi Rum and Petra. So I did choose this topic, hemorrhage into brain tumors. This is somewhat forgotten type of disease that we see, and as usual, we will discuss it from the clinical, radiological, operative, and pathological points of view. So whenever you see something like this, brain hemorrhage, it's not only hypertensive bleed or aneurysm, so many differential diagnoses go into this kind of lesions. So what is differential diagnosis? And what are the diseases that can cause this? You'll be surprised how many diseases can cause this. Systemic hypertension, of course, is the famous one. Whenever we see a bleed, we say this is hypertension. And the story of a man or a woman old enough, 60, 70, with non-hypertension on treatment, arrives to the ICU or the emergency room unconscious, and they do this, and they discover that his blood pressure is very high, and then this is systemic hypertension. So systemic hypertension has certain features and criteria that you diagnose by. But most of the cases, 50% of brain hemorrhage are due to systemic hypertension. Head injuries, very common in all kinds of countries around the world. Brain contusion and hemorrhages, extradural, subdural, you name it. Ruptured aneurysm, a very famous cause of intracerebral bleed. This is a rather giant middle cerebral artery aneurysm that ruptured into the Sylvian fissure here. Ruptured AVM, arteriovenous malformation. Rupture of arteriovenous fistula. It is something we forget about it. We think of aneurysms, AVMs. We forgot all the vascular pathology of the brain. And this is one of the forgotten pathologies of the brain, arteriovenous fistula. cavernomas, rupturing causing hemorrhage, hemorrhagic infarct, venous infarct. In this case, it was due to damage of or closure of vein of Labé on the left side. Serpilosinus thrombosis causing hemorrhage is usually bilateral. And this. Some interference, John, with.
I got it. Sorry.
Okay, no problem. These two, the antiplatelets and anticoagulation, are forgotten issues. People forget to ask patients whether they are taking these drugs. And I tell you, my experience, I was surprised that lots of patients don't think of aspirin as antiplatelet therapy. They just take it for granted, and they can have a bleed due to aspirin. So this is an essential question that I ask for any patient I want to operate upon. Are you taking aspirin or Plavix or anything of the same similar nature? Are you on warfarin or heparin or whatever? These are essential questions to ask. Antiplatelet therapy, just aspirin causing this. Anticoagulation therapy. Hematological disorders, we forget. We just lost the contact with these diseases. They don't exist anymore. They do. There are patients with deficiency of coagulation factors, factor 1, 7, 8, 9, 12, von Willebrand disease, etc., etc. This is a patient with hemophilia, presenting primarily with hemorrhage. Myeloid leukemia, presenting with hemorrhage. DIC, disseminated intravascular coagulation. And if you go and study this DIC, you'll find that the commonest group of patients who would get disseminated intravascular coagulation are patients with brain tumors. Coagulation disorders. This could be a congenital coagulopathy or acquired coagulopathy or a neoplastic coagulopathy. Cerebral angiopathies, so many. Primary cerebral angiopathy, amyloid cerebral angiopathy, autosomal dominant leukoencephalopathy, mitochondrial encephalopathy, as if these diseases don't exist. They do. And there are patients who will present to you with a hemorrhage like this, and you have to know what is the cause of this. Very common angiopathy is the cerebral amyloid. And how many of us would think of amyloid? It's a disease that is there. So stop thinking of the common. You have to think of the common and the uncommon and the very uncommon if you want to succeed in saving patients' lives. Vasculitis of various types and names. And this, drug abuse. We think that Middle East does not have drug abuse. There is. It is in our countries. It is in Jordan. It is in the Middle East. It is in Asia. There is a drug abuse, drug dealers, drug traffickers, users. And the commonest drug to cause bleed are cocaine, amphetamines in general, and the general sympathomimetic drugs like ephedrine. These are true pictures of patients who had bleed because they were on drug abuse. Infection. Can infection present with hemorrhage? Yes, fungal infection. Look at this, blood vessel with hyphae inside the blood vessel. So they rupture the blood vessel and they cause hemorrhage. Subarachnoid intracerebral hemorrhage, complication of rhinocerebral mucormycosis. Subarachnoid and intracerebral due to mycotic aneurysm, hyphae in the wall of the blood vessel, weakening it and causing rupture of aneurysm. So mycotic aneurysm, now you are in the emergency room and you get picture like this. Should you think of mycotic aneurysm? Yes, of course. All the causes of a brain hemorrhage must run through your mind with every case you see. Even if you see it every day, you have to think of it every day with every case, with every patient you see. You have to run through these causes of hemorrhage to reach to a proper diagnosis and therefore proper treatment. Now, the essence of the tonight is the hemorrhage into tumor. It is one of the causes of hemorrhage that you see on CT or MRI.
May I talk here, Dr. Ibrahim?
Sorry?
May I talk here?
Yes, please, go ahead.
So, hello, everybody. I'm Dr. Ala Addasi. I'm an oncologist and a hematologist. May I just emphasize that probably the most important test to be done for these patients with this differential diagnosis is a very good past and family history. You can detect disasters and prevent disasters by taking a very close past and family history from the patient. Now, very good screening test to be asked in a population that the majority of which is Muslim in this part of the world is what happened for male relatives during circumcision at birth. And you can unfold a lot of problems and disasters this way. Past history, family history, and operative history is of paramount. Taking very good drug history is extremely important because you'll ask the patient, are you on a blood thinner? And he would answer no. Are you taking aspirin? Oh, yes, I am. Are you on anticoagulation? And the answer is no. Are you taking a medication called Eliquis? Oh, yes, I am, etc., etc., etc. Are you on any blood thinner? No. Are you taking subcutaneous injections like enoxaparin for any other reason? Oh, yes, I am. These are very important things to be unfolded by taking a very good family and past and drug history. It's much more important than subjecting patients to something like bleeding time. You have to scrutinize all their medications yourself. You have to take a very good family history from them and from the mother if available, because she would know what happened with circumcision with this patient and his brothers and siblings. I cannot emphasize this enough because no screening test before this surgery would prepare you to prevent disasters like taking good family past medication has. Having a normal PT-PTT is not a guarantee that you're not going to have problems during surgery. Having normal platelets is not a guarantee that you're not going to have problems during surgery. Bleeding time on its own is a useless test. It's very operative dependent. It's very operator dependent, and I rarely order it unless I'm looking for something in particular. Okay? And I apologize for the interruption and
Not
for the
at all,
quality of
Ala.
my voice, which is muffled by 8 masks on my face.
No problem, Ala. Thank you very much. Ala is an hematologist and oncologist, and I think people would benefit from the words of wisdom he just said. The history, the drug the patient is taking. People are forgetting these things. They just go for the MRI or CT without history, without good physical examination, and then mistakes can easily happen. Thank you, Ala. So one of the causes of hemorrhage is hemorrhage into a tumor. And this, surprise, surprise, 3.6 of all intracranial hemorrhages. I can tell you something more. In some series, it's up to 10% of intracranial hemorrhages are caused by hemorrhage into a brain tumor. So this is a common thing. This is a common cause. And this is the seriousness of it. Intracranial hemorrhage could be the first sign of a previously unsuspected, undiagnosed brain tumor. And what's the seriousness of the matter? This bleed may mimic cerebrovascular accident, say hypertensive bleed, whatever, and thus affect diagnostic workup, treatment, and outcome. And I will show you this in my personal series. And when hemorrhage occurs in the tumor, it is not inside the tumor only, which is 85% of the cases. It can be just subarachnoid hemorrhage, subdural hemorrhage, intraventricular hemorrhage. Again, how many of us, when you see a subdural hematoma, think that this may be caused by a tumor, that this may be caused by AV fistula, this may be caused by rupture aneurysm? And when you look at these tumors, why do they bleed? There are certain features. There is tumor necrosis inside, vessel wall degeneration and weakness. The tumor has infiltrated into the blood vessel wall, thrombosis of blood vessels are ruptured, and again, ruptured vessels. Example of hemorrhage into a tumor, infarction into a tumor, thrombosed vessels. Again, when we speak about hemorrhage into a tumor, it's not only hemorrhage, it could be infarction, like we see in the pituitary apoplexy. Evidence, thought was feeding vessels may rupture easily with these tumors and they can cause hemorrhage. So let's concentrate into hemorrhage into a tumor. It's not only hemorrhage, it could be necrosis, infarction, it could be hemorrhagic infarction, it could be pure hemorrhage. Remember this, and the best example is the pituitary apoplexy. So I put it first. So this is pituitary with apoplexy, and you see here infarcted areas, and here you see bleeding areas. So apoplexy does not mean just hemorrhage, it can mean thrombosis, it can mean infarction. Like the same thing we see with other tumors. Examples of pituitary apoplexy in my series, like this, you can see the hemorrhage inside. You can have it in microadenoma, you can have it in macroadenoma. So you can see, like in here, and in here with this giant macroadenoma with this hemorrhage. These are cases of, in my series of pituitary. And this is, in fact, pituitary apoplexy, a giant one. So what are the brain tumors that are known to have this high incidence of hemorrhage? The highest incidence is in the malignant tumors more than the benign tumors. And in the malignant tumors, the grades of astrocytoma, grade 2, 3, and glioblastoma multiforme, etc., and in metastasis. So the ones I put in red are the ones that are common: glioblastoma, astrocytoma, oligodendroglioma, and in the benign group, pituitary adenoma, schwannoma, cavernous meningioma. But it can occur, and I stress, it can occur in any brain tumor. And if we take the metastasis, it's common in certain types like papillary tumor of the thyroid, hepatocellular carcinoma, renal cell carcinoma, malignant melanoma, choreocarcinoma, bronchogenic carcinoma, breast carcinoma. Cases in my series: astrocytoma grade 3 presenting as hemorrhage, pleomorphic xanthoastrocytoma presenting with hemorrhage, glioblastoma multiforme presenting as hemorrhage without patient knowing, without him being diagnosed or suspected to have a brain tumor. Oligodendroglioma, they are common. They are the ones that we should think of in having a hemorrhage inside them. Ependymoma is not an exception. Medulloblastoma, whether they are dealing with the medial type or the lateral type, the 5 histological types, you may get hemorrhage into tumor. As a first presentation, central neurocytoma presenting as hemorrhage. Choroid plexus carcinoma. Of course, we have choroid plexus papilloma, the atypical type, and the choroid plexus carcinoma. The 3 of them, choroid plexus, benign papilloma, the intermediate atypical type, and the choroid plexus carcinoma can present with bleed. Ganglioglioma, true case, presenting as hemorrhage. DNET, presenting as hemorrhage. Teratoid rhabdoid, common in children, and they can present with hemorrhage. CNS lymphoma, primary CNS lymphoma, or secondary CNS lymphoma for that matter, they can present with bleed. Meningioma, benign tumor. Of course, we have the grade 1, grade 2, grade 3, but we don't think of them as presenting with hemorrhage. They can, and I will prove this to you. And this is one case of hemorrhage into meningioma and the histological presentation. Looking into literature, meningioma manifesting itself as intracerebral hemorrhage, the first manifestation. Patient never had any diagnosis, never been suspected to have brain tumor, but then he had some signs and symptoms and CT MRI showing hemorrhage. That was hemorrhage into meningioma as a first presentation. So why do we have hemorrhage into meningiomas? How do they bleed? What is the hypothesis behind that? They are
May I have a very
hypervascular.
quick editorial comment, Professor Sbeah?
Please do.
Now, to emphasize the importance of considering underlying pathology whenever a patient presents with a brain hemorrhage. Now, brain metastases are more prone to hemorrhage than primary brain disease. And the most commonly seen would be lung mets and breast cancer. Lung cancer, breast cancer, just because these are the two most common cancers in the world, and most prone for CNS metastases. But any brain tumor, primary or secondary, can bleed, including rare entities, as you have alluded to from your own series, like primary CNS lymphoma that can present as brain bleed. The message we have to emphasize again and again, when you get a patient with a primary hemorrhage in the brain as a hemorrhagic stroke, make sure that you have examined the patient well to make sure he does not have a clear primary, like a breast cancer. And when you intervene surgically, make sure you have enough tissue to look for an underlying malignancy, be it primary or second. I cannot emphasize this enough.
Thank you,
Okay,
Ala.
thank
Thank you
you.
very much indeed. We'll proceed and stay with us, please. So meningiomas as tumors that can present as a bleed. As I said, the hypothesis here is that they are vascular tumors, that some abnormal vessels inside them may rupture, the tumor may get necrosis, the neovasculature as it grows over years are thin-walled, the feeding arteries are tortuous, rupture of stretch bridging veins if you have a parasagittal meningioma, and if you have a concomitant disease. So the patient may have a meningioma, he is not diagnosed, and then he would get seizure, and the seizure would cause a bleed, and the patient would present for the first time as a bleed. So hemorrhage into meningioma may be spontaneous, without any incident, without any history that goes with, or if you do embolization, or after doing stereotactic radiosurgery, or post-operative. People say that location of meningiomas is unrelated to the risk of the bleeding. Some people say no, convexity are more at risk than the skull base. My experience is that there is no relation with the location of meningioma. You can have hemorrhage intercortical meningioma as well as a skull base meningioma. Angiomatous meningioma more risk? The answer in my series, no. It can happen in any type of the 15 types of histological types of meningiomas. Is malignant meningioma more at risk? The answer is no. They are all at risk. Grade 1, grade 2, and grade 3. And the bleeding here in the meningioma could be inside the tumor, intramural, or outside the tumor, subdural, subarachnoid, or intraparenchymal. Remember that cranial meningiomas, if they have a bleed, it's much more than the spinal meningiomas. This is a case of benign meningioma presenting with subdural hemorrhage. Look at the initial CT. This is subdural hematoma. How many of us think of underlying cause for this? We just go for bare hole evacuation without thinking any further than the surface. So this is the tumor, and this is the subdural, and I will allude to this later on. Meningioma with hemorrhagic onset, parasagittal. Lateral ventricle is known to have meningiomas, usually on the left side. Here in this case, it's on the right side, but it's okay. And they can present with hemorrhage. Undiagnosed, unsuspected brain tumor presenting to you with hemorrhage. This is the message. Hemangiopericytoma, like meningioma, they are vascular tumors. Previously, they were called solitary fibrous tumor. So solitary fibrous tumor is the same like hemangiopericytoma. And this entity can bleed and present like a bleed. Papers, solitary fibrous tumor, hemangioblastoma, presenting with intracerebral hemorrhage. Hemangiopericytoma, presenting with acute intramural hemorrhage. So this is serious. This is real. This is not luxury of information. This is essential information. Again, hemangiopericytoma, solitary fibrous tumor presenting as hemorrhage. So you may think easily that this is hypertensive bleed. Simply why? Because you have a very limited pathologies on one's mind to think further. Intracerebral hemorrhage is hypertensive bleed, aneurysm, or AVM, period. It's not the only 3 causes. It is 300 causes. Germinoma presenting like a bleed, supracellular bleed. Chordoma presenting like a bleed. Chondrosarcoma presenting like a bleed. Pineal locus tumor presenting like a bleed with acute hydrocephalus. Vestibular schwannoma, yes, it can present with a bleed like this. As I've said, and as Ala alluded to, metastatic tumors are much commoner to have a bleed than the other primary tumors, as we said before. And as I said, the thyroid, hepatocellular, renal, melanoma, choreocarcinoma, bronchogenic breast, and hence what Ala was alluding to, examination. It is not enough. People are forgetting to have good history and physical examination because we have ready CT, MRI. People look at it and they go for action. This is wrong. We have to go to the basics. We have to go to think about differential diagnosis, about history taking, about physical examination. This is a bleed from a thyroid. And I tell you, I've seen these cases, thyroid and colon carcinoma. When you operate upon them, they bleed like hell. They bleed and non-stop. They are really frightening. Melanoma is the same also. Again, Ala mentioned that how many of us look into between the fingers, underneath the fingernails, toes, to look for a melanoma, which nobody thought about it. Choreocarcinoma, very serious. In females of childbearing age, metastatic choreocarcinoma should be considered in the differential diagnosis of any intracerebral hemorrhage. This is serious. Choreocarcinoma in females, especially childbearing age. Colon metastasis, they bleed again like hell. I'll take you now through my personal cases, my personal experience with these hemorrhage into tumor. Case number 1, a 44-year-old female patient, Jordanian. She had visual disturbance of 2 months duration. She had glasses, she had this, she had that. She had headaches. She came to us, and you can see there is a supracellular hemorrhage. What is that? Is this an aneurysm? Hemorrhage, 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 there. And the hemorrhage seems to be in the optic chiasm. Angiography, there's no aneurysm there. No vascular pathology to see. Visual examination, poor vision, especially on the left side with bitemporal hemianopia. This is the optic OCT and the visual feeds, very poor visual feeds, and some atrophy of her fibers of the optic nerve. Now we'll go for the surgery. I made this summary of this video so that it's quick. This is the optic chiasm, and inside the optic chiasm, there was this lesion, very vascular lesion. I'm trying to separate it and take it out from inside of the optic chiasm. So we're separating this lesion from the inside of the optic chiasm. And what was the histology? Histology from Dr. Sam Al-Fasa, consultant pathologist and cytopathologist, American boarded, chiasmatic tumor cavernoma. So it's not simple word of aneurysm and AVMs. And I just really hate when I see reports of MRI and CT, no aneurysm, no AVMs, as if the whole vascular pathology of the brain is either aneurysm or AVM. People, the vascular pathology of the brain is so varied, is so wide, is so extreme that you have to expand this knowledge and differential diagnosis. So this was a cavernoma of the optic chiasm, and here are the slides to support it. I wonder if Dr. Abu Farsakh is around to make his comments. Are you around? This is the immune staining that Dr. Farsakh does for us in each of the cases to make sure that we have the correct diagnosis. So if you are there, Hussam, please come forward. Post-operative, you can see that we have removed the lesion. And this is long follow-up of this patient. She did very well. Her follow-up, most importantly, that her vision improved, and not only subjectively, but also objectively, and we demonstrated that. For this, we sent this case for publication, and it was published in the Interdisciplinary Neurosurgery 2020, anterior interhemispheric approach for microsurgical resection of an optic chiasm cavernoma, Ibrahim Soleil, Hussam Al-Farsakh, and others. And here's the paper, if you want to look at it. As I said, her vision remarkably improved. Case number 2, a 19-year-old male Jordanian patient, sudden severe headache and vomiting, several hours duration, diagnosed as gastroenteritis. It was not gastroenteritis, it was hemorrhage into the brain, hemorrhage into a lesion in the brain. That's the lesion and the hemorrhage inside it. The MRA, MRV did not show any underlying vascular pathology. I was not happy with the MRA, MRV, so I went for conventional angiogram. And indeed, there is a tumor blush here. You can see tumor blush. Of course, when we do angiogram, we do 6 visual angiogram, 2 external carotids, 2 internal carotids, 2 vertebrals. Now let's see the surgery. We record our cases in 3D for the sake of teaching, but here I'll change it into 2D because not all the people have the appropriate glasses. So this is the approach. Opening the dura, and you can see the hemorrhage. And this is the hemorrhage and region. Very fresh bleed. This is, as you know, in the left temporal area. And you can see the lesion, very vascular bleeding lesion. This is the floor of the middle fossa, temporal fossa. And this is the hemostasis and closure. So, what was the histology? From Dr. Abu Farsakh, again, atypical meningioma, grade 2, with a brain invasion and predominance of a small cell component. So, grade 2 meningioma has bled, and it was the first time the patient or his family knew of him having any brain tumor. Look at this, hemorrhage, big spaces inside the tumor. Again, the immune staining that goes with it.
Hello?
Hello, yes? Anybody wants to make any comment?
Yes, sir. Go ahead. I guess not.
It's all right. And this is the patient, immediate post-operative, young man, and he did very well. Case number 3, 77-year-old male Jordanian patient with sudden headaches and visual disturbance. 77-year-old male patient. Meningioma here, meningioma there, meningioma here, there, and this large lesion. So you would suppose that this is multiple meningiomas, so this is meningiomatosis. CT showing this. But then there is this subdural hematoma here. You can see it here. Very good demonstration of the lesion and the subdural hematoma. Again, MRA, MRV did not show any underlying vascular pathology, so we went for surgery. And the tumor was invading the bone, so we drilled the bone. Let's look at this tumor with hemorrhage into it, extensive hemorrhage. This is the midline here. This is the parasagittal area. So we're evacuating the hematoma from the subdural space. And you can see why. Because one of the bridging veins has ruptured and caused this subdural hematoma. And this is the end of it. Drilling the bone. Histopathology from Dr. Farsakh, meningothelial meningioma, grade 1. As you can see the hemorrhage between the meningioma cells. You could see the bone invasion, which we have seen in the bone flap. You can see the wide vascular spaces within the tumor and the, as I said, the immune staining that goes with it as a routine. And this is his post-op. And this is the man himself. This is the flap I used, triangular flap. And this is him after that. Case number 4, 77-year-old man, Jordanian, with sudden headaches, visual disturbance, and severe left-sided weakness. And look at the MRI, you can see hemorrhage here, and you can see another lesion here. So major hemorrhage here, but there is another lesion here. So one area and another, one area and another. Coronal showing you the hemorrhage. Sagittal showing you the hemorrhage. MRA, MRV did not show any vascular pathology. We did chest CT and abdomen and pelvis. Nothing in the abdomen, nothing in the pelvis. But the chest showed that there is a lung lesion, which was a primary lung carcinoma. So we'll go for surgery now. You can see the brain being bulging and stained, and we did this cortical incision. Again, inside, we encountered this tumor with hemorrhage inside. We are going around it, and I must stress this point, that if you have brain tumor with hemorrhage into it, you have to remove the tumor totally. You don't leave any piece, because that piece, if you leave, will cause another bleed within the same night or the following night of surgery. So you go around it and you try to remove all of it completely. So my aim here is to have total excision of the lesion, leaving nothing inside. Then you go for hemostasis. And Dr. Samir Amr, another histopathologist, did the study on these slides and the specimen, and he diagnosed metastatic, poorly differentiated carcinoma. So this is a man with metastasis. He presented with a bleed as a first presentation. I don't know whether Dr. Samir is around. Are you around, Dr. Samir? If you are, please come forward for comments.
If he's not,
Hello.
may I have a quick comment? Dr. Samir, are you around?
I am around.
Please go ahead, Dr. Samir.
Okay, well, this tumor was composed of sheets and clusters of highly malignant epithelial cells. And the nuclei were quite large, lots of mitotic activity. And considering the history of lung tumor, I thought I work it up on immunohistochemical basis for possibility of primary lung cancer, whether it is a poorly differentiated squamous cell carcinoma or an adenocarcinoma or a neuroendocrine carcinoma.
Right.
So we did cytokeratin 7, which is a marker for lung adenocarcinoma, as well as thyroid transcription factor 1, which is also another marker for lung adenocarcinoma. We did also P63, which is a marker for squamous cell carcinoma. And we did synaptophysin, which is a marker for neuroendocrine tumors. And it was strongly, uniformly positive for synaptophysin. So we conclude that this is a large undifferentiated or poorly differentiated neuroendocrine carcinoma.
Right.
Thank you.
Dr. Samir. Thank you very much indeed. Dr. Ala, do you want to make a comment?
In this setup, I think Dr. Samir would agree that neuroendocrine markers in this setup with a brain metastasis and a brain and a lung lesion, this is small cell lung cancer until proven otherwise, because they would have neuroendocrine features on staining. So this is a common scenario, unfortunately, with smokers. They present with brain lesions or brain hemorrhage. You look in the lung, you'll find the lung lesion, highly associated with smoking. Please quit smoking. This is small cell lung cancer until proven otherwise. And this is such a high incidence to the extent that all small lung cancer are subjected to prophylactic cranial irradiation, even if the lung is negative, even if the brain is negative as presented.
Right. Actually, this patient has been referred for radiotherapy, and I think he started the radiotherapy already. Thank you, Ala. Thank you, Dr. Samir.
Most welcome, sir.
And this is the patient, post-operative. His left-sided weakness markedly improved. And this is his post-operative CT scan showing total removal. I insist that if you have a bleeding into a brain lesion, you have to remove the lesion completely. Never close there any bleeding inside, because there is a piece there. So my motto, if there is a bleeding in the field, I know there is a tumor left, and I just persist that I remove the tumor totally. Case number 5.
Dr. Ibrahim, if I may
Please.
have a small
Yes, please.
comment.
Yeah, Dr. Musa Saleh is a general surgeon. Please, Musa.
And the patient is my brother.
And the patient is right.
Actually, I just want to add to to confirm what Dr. Samir said about the large cell endocrine carcinoma. It has been confirmed by re-examination of the KHCC. You know, when you send people to the King Hussein Cancer Center, they retest the specimen of the blood and everything, and they confirm the diagnosis of Dr. Samir. It's a neuroendocrine with probably small cell minority of the tumor. Yes, he's due to start his radiation probably Sunday next week. He's much better now, only after surgery alone. Yes, just a bit of addition to your
very informative piece of information.
Yes.
Thank you, Musa.
Yeah.
Thank you very much indeed.
Okay.
Case number 5 is a 59-year-old female patient from Iraq. In her home country, she had a sudden onset of loss of consciousness with right-sided hemiplegia. And here you are. MRI shows this hemorrhage into a lesion. But this, unfortunately, was diagnosed as primary intracerebral hypertensive bleed for no good reason. It has all the features that is hemorrhage into something. Yet this patient was diagnosed to have left frontal intracerebral hemorrhage with dexamethasone, this, that, and the other. Her symptoms improved, so good. Her stroke is being treated and go home without any further investigation. She came our way with severe signs and symptoms, severe and continuous headaches, and again, the MRV did not show any underlying vascular pathology. I insisted on doing conventional angiogram, which shows the same, no underlying vascular pathology, and we went for surgery. Again, here we will change the 3D, which I always record my cases as a 3D. It's good for teaching. We'll turn it into 2D. Again, I'll go through that quickly. You can see here vascular tumor with hemorrhage into it. Again, I don't stop unless I don't see any trace of a tumor. Even if it is malignant tumor, I go until I find no plane of cleavage. I'm not sure whether this is a tumor, and then I stop. But in this case, I persisted in doing radical excision of the tumor because this is the motto: don't leave any piece of the tumor inside. You can see this is the anterior canal base, the frontal lobe. So we have done total radical excision, and here the hemostasis and so on. What was the histology from Dr. Farsa? A glioblastoma multiforme. Again, this patient did not suspect. Her family did not know. She was not diagnosed to have a tumor. She presented with sudden loss of consciousness. And people, because they are not deep enough, they diagnosed her as hypertensive bleed. This is the message. If you don't diagnose well, if this patient remained at home, she would have died. Because,
may I comment, Dr. Bahir?
yes, please don't go ahead.
And again, we continue repeating the same point and hammering the same nail on a weekly basis. You cannot dismiss this as a brain hemorrhage without ruling out an underlying path. If you don't look for it, you don't find it. GBM is the most common primary brain tumor, excluding meningiomas, of course. And by not looking at them, you are condemning the patient to a miserable fate. It's a bad tumor even when well treated. But there's no reason why not to look for underlying tumor in any patient who presents with brain hemorrhage. And I believe this is the main message of this meeting today.
Absolutely, absolutely. Now I'll go for this is the histology. Again, hemorrhage inside the tumor cells. The usual immunostaining that we do, extensive immunostaining. We don't stop. We don't leave stone unturned. And this is the postoperative radical excision of her tumor. As you can see, she did well postoperative, and she received radiotherapy for her remnants of that we don't see of the glioblastoma multiforme. Last case, case number 6, very unusual and very emotionally upsetting for me. This is a 22-year-old female patient, 22, recently married, got pregnant, prima gravida, admitted for normal vaginal delivery. On induction of labor, she became unconscious with one-sided fixed dilated pupil. What's the diagnosis? Oh, this is the usual coagulation that we see with the pregnant ladies. This is sad. 22-year-old patient. Of course, they continued delivery. They delivered a baby boy, a very precious one, of course. But she was unconscious on a ventilator, and her pupil became fixed dilated. That's when I was consulted and looking at this massive hemorrhage. This cannot go underneath any label of any of those coagulability because there was nothing to support it. People would come forward with fancy names of, I don't know, normal whatever syndrome that we see in pregnancy with no good evidence. And if somebody gave it a label, then everybody would follow that label. I refused to accept that label. For me, this was serious. This did not and was not been approved by any test or whatever. And to me, 22-year-old patient who just delivered a baby deserves to live. Extensive hemorrhage. MRA, MRB did not show any underlying vascular pathology, but to me, this is not enough. This is a young lady, I need to know. So we proceeded with 6-vessel angiography, 2 external carotids, 2 internal carotids, 2 vertebral carotids to see what is the cause of her hemorrhage. We could not see anything on the conventional angiogram. Of course, this is external carotid, this is vertebrobasilar, and this is the right-sided internal carotid with the capillary phase and the venous phase. And this is the left-sided, where the bleeding is, left-sided angiography, just showing displaced vessels, but no cause for this hemorrhage. So we went for surgery. When I took her to theater, she had a fixed dilated left pupil because people were happy with the diagnosis of whatever hematological disease that people would see with pregnancy. So this is the cortical opening, and again, immediately I encountered the bleed. So I proceed taking the clots out. Each piece of this clot is very important. Now I'm encountering some blood vessels, abnormal blood vessels here. Each piece is very important. I tell you, when I was operating on this lady, I was praying heavily to God, please, God, be with me. I want to help this lady. Especially that I knew she delivered a baby boy, beautiful baby boy, and it was her first delivery, first baby. Again, you can see that there are some abnormal vessels here. My aim is to remove it totally, not leaving anything, because I don't know what's the pathology. In this blood clot, you may find an answer to why did she bleed. Again, look at these blood vessels. They are abnormal blood vessels. Abnormal blood vessels, dilated. We are here getting into the anterior horn of the lateral ventricle, and these vessels are tortuous going into the anterior horn of the lateral ventricle. This is not normal kind of vascularity. And what's the histology? Arteriovenous malformation. Why? Why did we not see it on the angiogram? Because many cases we have seen this. You do an angiography, you don't see it, simply because theory behind it that the AVM has ruptured and destroyed itself, as it were. This is the histology from Dr. Farsakh, and he can show you these normal blood vessels that are rupturing here. They have ruptured. Abnormal, dilated, tortuous blood vessels. Or the immune staining of the blood vessel wall. And this is the post-operative CT and post-operative MRI. Patient started to recover slowly but surely. She had dense weakness. But look at this. A month later, she came and visited me in my clinic with her son. This was my request to her husband and father. She recovers, please let her come to my clinic with her son. I carried the baby as if it was mine. I looked at this girl as if it was my daughter. And I tell you, there's no satisfaction in life more than this. This is her last visit. Beautiful young lady functioning back as a wife, as a mother, and as a daughter for her family. To me, this is the essence of surgery. To me, this is why we are practicing. Thank you.
Okay, Radab.
Dr. Ibrahim. Thank you, Professor Ibrahim, for the great presentations and the very invaluable shared experience, actually. It's a tremendous work, and I know it's kind of, maybe the last case was kind of emotional for you. We do appreciate your great effort you give for that patient. I know how it feels when you give a new life for your patients.
Absolutely.
That was, yeah, we do understand. We do understand the happiness and the pleasure you get once you had such successful and yet complicated cases. And we do really appreciate from the heart, from deep inside our heart, the shared experience that we should all take lessons from.
Thank you.
So, well, it's really a source of proud for us and for you in the first place to have such great work with such successful outcome.
I can see Dr.
So,
Victor.
Dr. John.
Victor, do you want to make a comment?
Yes, Professor Ibrahim, really a nice lecture. The last one was very emotive, a great work in the surgery room, but also in the office. It is really good to see these results, the outcome, and the picture with the patient and his child was very, very nice. So we want to invite you in 20 days more. We are going to have a lecture here in Mexico. The first two lectures are going to be in Spanish, and the last one could be your lecture, about 15 or 20 minutes. We would like you to agree with this lecture, Professor Ibrahim.
It is my
and
pleasure.
once again, very, very great lecture. Thanks.
Thank you. I'm happy to join you. It's a pleasure and honor to be with you. So just get me the details. I think you've got my number, so send me the details and we'll discuss it. But it's my pleasure and honor.
Thank you so much.
Pleasure. Any questions, any comments? I'm happy to answer.
Can I say something?
Please, Dr. Musa.
A very emotional end, Brain. I very much appreciate this. I very much appreciate your tears. We all live these moments as surgeons, and probably this is the core issue of our life, our philosophy, our practice, our experience. What actually what we get paid for is not really the physical effort we do in operating theaters, rather for the great burden you feel on your shoulders when you operate on these people. Probably how gratifying to see the 21-year-old girl with her son. Probably nothing in the world can do you better than this scene. I so much congratulate you actually for this. Being together so long, and I from myself, from my family, actually, great gratitude for what you did for our old man. He's much better, as I said. He's walking now, and probably he's due to have his radiation. But great thanks to you, and great appreciation to your effort, not for this very case, but for all what you do. You are a very eminent surgeon, not only locally in Jordan, but in the Middle East, probably in the world. Well, great thanks again. Brain.
Thank you, Musa. Thank you very much.
Very good effort. Great.
Thanks.
Thank you.
Can I say one word, Doctor?
Of course.
Yeah.
I also, I'm a pediatrician, on behalf of all pediatricians and doctors. You made me cry with you. It's very emotional. I also add to what Dr. Musa have said, all the pleasure that you gave us today. And I thank you again. Brahim is known for this. Thank you.
Thank you, Jalil. Thank you very much indeed.
Okay, any more comments, questions? Okay, great. Dr. Sabea, what's the talk for next week?
Choose to speak about falco-tentorial meningioma, a very specific subtype of meningioma that originate at the junction of the falx cerebri and the tentorium cerebelli. These are very difficult, complicated cases that warrants complete, utter, deep knowledge of the anatomy of that area because of the venous connections there. So I choose to discuss this and present some of my cases.
Okay, excellent. Okay, before we go, Dr. Sabea, if you don't mind, I'd like to show the panel what's going on and show the internet audience
John Bennett.
what's going on this week. Hey, Victor.
Yes, I think Dr. Maurice Desalé wants to say something.
Okay, go ahead.
But,
Go ahead. Go ahead.
He's without sound. Microphone
Okay.
is off.
Maurice, please just unmute yourself and please come forward.
I don't know. Well, let me just go through this. You can always turn.
Sure,
You can
sure.
always come back. You can see my screen, right?
Yeah,
Yeah. Okay. This is your presentation, Dr. Sabea. It's on live on YouTube. It went to a lot of. It's live on Facebook. Anyways, Hyperion is having a big conference on the 20th and 21st. And matter of fact, Victor is going to be speaking there, right, Victor? Yeah, Victor's giving a lecture on anatomy. That's this weekend. Okay, and there's Dr. Lawton and Chris are having a anterior communicating arteries aneurysm on Thursday night at 6 o'clock Eastern time. Yuha has his grand rounds Friday morning 7 o'clock Eastern time, 8 o'clock. And Dr. Sabea, we have a Egypt webcast
yes.
on the 26th. I don't believe you're speaking at this one.
No, no,
No. But yeah, we look forward to everyone coming. And
absolutely.
I'd like to thank you very much, Dr. Sabea, for all your work and all your time that you've been teaching.
Thank you very much, John. And we'll see you next week. And I thank all the panelists and the participants. I think that was a very fruitful discussion tonight we had. And I look forward to see you all next week. Thank you very much indeed. And goodbye.
Okay. See you, Doc.
Thank you, Professor.
Thank you.
Thank you
Thank you.
so
Thank
much.
you.
Okay. Very good. Thanks, Dr. Sabea. Hey, Dr. Cabullo. How you doing?
I'm fine, thanks, Dr. Bennett, and you?
Good. You know Victor, right? You've met him many times.
Yes, good evening to my father, Shbei.
Thank you. Thank you.
Okay.
Oh, there he is.
Cabullo, nice to see you.
See you. Bye-bye.
Thank you so much.
Nice to see you, Dr. Cabullo.
Victor. Nice to see you too.
I see Maurice is there. Maurice, you want to say something? Unmute yourself, Maurice. Just unmute yourself.
Yeah, if you want to meet Dr. Sabea, come on in and say hello. It's maybe a chance of a career. You never know where you're going to end up. Train, right, Dr. Sabea? You never know where you're going to end up training.
Absolutely. Maurice is a very senior neurologist in Jordan and one of the best in the Middle East and one of the best in the world, to my mind.
Oh, okay.
So Maurice, unmute yourself and let's
let me see if we
hear
can
from
get Maurice in here. There he is. He's trying to talk. He's got to unmute himself. Unmute yourself. There you go. Okay. There we go. Oh, I thought it was working. I think you have a problem with your computer, Maurice. Maybe your volume. Turn your volume up because your sound system's hooked up. I can see it, but it's not getting any volume. So your sound is not working at all.
No, we cannot hear you, Maurice. There's something wrong.
Yeah, something wrong with your sound system.
It's
You have
okay.
to check that.
Thank you, Maurice. Maurice was the neurologist taking care of the young lady we showed last, and he really took good care of her until she recovered and went home. So thank you, Maurice, for that.
Okay. Is it from Jordan? From Jordan?
Yeah, Maurice is from Jordan. Yes. He's a
Okay,
very
very
senior neurologist, and he's passing his time between Jordan and England. He's teaching in England. Yes. So he's very, very eminent in neurology.
I wish you could hear you, Maurice.
We need to hear
okay.
you
The next time.
next time.
Next time.
Okay, so I'll say goodbye and see you next week.
Thanks. We're going to hang around here.